Good morning. This is Carol Yarbrough, and I am speaking to you from San Francisco, California. And we all know that nationwide, we're all under the same CMS rules and guidelines and foibles. And we share quite a bit of the same Medicaid and private payer rules and sometimes denials. So, pretty much, I'm going to lay out for you what's happening during the PHE, the public health emergency, while we're under the COVID-19 dictates from the federal government, and what we can expect going forward. And so during the live Q&A during this recording, Michelle Hager of Blue Cirrus will also be answering questions along with me. So welcome to Michelle as well. So telehealth and telemedicine, we talk about the definitions all the time, and it would not be a telehealth or telemedicine presentation without going over terminology and definitions. So yes, they're often used interchangeably and may have different meanings and means, I guess averages, depending on where you are and who is covering, paying for the health services. So pay attention to the payer that you are looking at, and pay attention to how they're using the terminology. Typically, it means the provision of direct healthcare services to a patient, the direct healthcare. You're practicing medicine. Telehealth is broader because it covers other types of activities, education, public health, provider to provider interactions. I also like to mention mHealth because that was a new term to me prior to seeing it in use before the PHE. Now we're all getting all sorts of notifications on our phones that are coming. Phones are our smartphones that are coming from our local government saying, this is the COVID rate of the day. Remember, you're sheltering in place. There's been an increase of cases in your area. And on the West Coast in the last few weeks, we've also had air quality index indications. So this is called mHealth, where a local government can push out public health notifications. And again, some states have a legal definition for the terms used, and some states use both to mean different things. In short, note who your payer is and what the contractor definition says about that definition. Okay, terminology, again, more definitions. The originating site where the patient or your client is located during a telehealth interaction, telemedicine interaction. A distant site is where the provider is located during the time of the interaction. And the modality, the way the service is provided. So many times lately we hear that, oh, telehealth is a different way to provide service. Oh, it's a different type of service. And time and again, not only have we said it as longtime provisioners of telemedicine, I was on a call yesterday where I heard someone who used to work in the Obama administration mentioning that, gee, telehealth is just a modality. It's another way to deliver care. It's not different care, it's all patient care. So it was reassuring to me to hear somebody that was so high up in the organization had, adopted that as well. So modality, we have live video, real-time interaction via video. We have a smiling provider. My provider smiles like that at me sometimes, especially now that my cholesterol level's gone down. Store and forward, where you capture a picture and you send the information. It's not real time. It's asynchronous. The provider has time to review and consider and then formulate an answer and get back to the patient. And remote patient or remote physiological monitoring, There are multiple definitions of what this means. There were clarifications given in the latest draft of the Medicare physician fee schedule, that kind of blew away what I thought remote physiological monitoring is. And I'm hoping by the time that this recording is aired that we'll get clarification on that and can provide it to you. But in my sense, it's continuous monitoring of a patient's condition from a distance. We like to think it's in real time. So the continuous monitoring is that there is a transmission of that data, and it's not patient entered. It's not recorded by the patient and then provided on a chart. And other times, it might be perfectly valid to have a patient self-report, such as the blood pressure, hypertension codes that are available now. So it just depends on your patient population. Say you're managing a very large group of risk-based care patients, and it'd be fine for them to self-report, and then consider that you're perhaps managing a patient population that is a little bit more directly associated with a particular condition, say hypertension and kidney disease or COPD. So really about, again, the modality that's most appropriate at the time for that patient. We can't talk about telehealth without talking about HRSA. In the before days, before COVID-19 and the public health emergency, the PHE, we did have to pay attention to where the patients were located, in particular for Medicare, and really, in reality, most of the payers. So at this URL, you can find a really great interactive website. It works great. I met the fella that, his name's Stephen Hirsch. He's the fella that maintains this site. He does a great job of keeping the addresses updated. But it'll tell you, yes, you've put in an address eligible for Medicare telehealth payment. It's going to be in a rural geographic area where there are a minimum of or a minimal amount of healthcare available. This other address put in here, say in Spokane, Washington, well, there must be a ton of doctors available. So that is not eligible for telehealth payment. And again, as I mentioned, that was in the before times. So to dig right into it, let's get to it. We're going to compare what's happening now and what's going to happen in the future. So I mentioned the HRSA geographic limitation because now urban areas are allowed and the patient's home is allowed. So in terms of billing and reimbursement for inpatient at a facility or, any hospital, Medicare has clarified, or CMS has clarified on those afternoon calls that we've grown to love on Tuesday afternoons. They've clarified, is your provider located within 250 feet of the main hospital? Well, and if you're seeing the patient via a device, like via video, or you're talking to them on a telephone, or you're talking to a resident via telephone, it's not telehealth. Is it live or is it Memorex? It's live. So you're going to bill as you normally would for time on the floor. If your provider is off campus, then it's telehealth. Other things that are important that we can do admissions now via telehealth using the 99221 through 23 codes with your AI modifier. And of course, if CMS, if it is a telehealth encounter, modifier 95, place of service hospital. Most commercials are following this. Post PHE, the originating site is going to revert. We will no longer be able to see patients remotely like that. Will the CPTs revert? Yeah. they've added a lot of codes into category 1, 2, and category 3 during the PHE, but you'll have to look at that draft MPFS and then the final to see which CPTs will continue to qualify as telehealth or what's allowable in terms of using technology. And the modifiers, yeah, everything's going to revert. No modifier for CMS. Say you're an emergency department provider. Again, urban is allowed. Use the same codes as before for stroke. Use your same modifiers. That is the, okay, write it into the chat because I'm blanking on it right now and I'm recording this for you. So use the same modifier, same codes as before the PHE. What they're allowing currently is that you can use the provider being offsite, seeing the patient in the ED using actual emergency department CPT codes. Fantastic. Then you're using place of service 23, modifier 95, instead of the consult code that you would be using, for instance, for stroke. Post PHE, originating site reverts. So everything's back to normal, back to abnormal. Teleproctoring of major and minor procedures will go on until the end of the PHE in the calendar year. As you know, the codes that have been added at the end, when the end of the public health emergency is declared over, the codes that are in the category 3 column on the telehealth CPT code list from CMS, and I'll give you the resource for that at the end of this presentation, those will be accepted until the end of the calendar year following the end of the public health emergency. Simple. And then, yeah, so I know a lot of folks have been using iPads to round in the ED and using iPads for really innovative things to maintain distance between your registration desk and your patients who are ill. I think that automated registration to maintain all hygiene, a lot of that's going to remain. I think so. It just makes sense. For ambulatory or provider-based type of visits, yeah, geographic site limitation is waived. You can see patients at home and get paid. Finally, 5 years of being in my telehealth bubble has, we've ranted about this. We want to see patients in their home. And there have also been additional codes added to maintain health equity for our healthcare to prevent the spread of COVID-19. The addition of the telephone codes, 99441 through 43. And then, as you've seen on the telehealth list provided by HHS and CMS, there are audio-only options for existing telehealth codes, a lot of these in the behavioral health field. Again, modifier 95, place of service 11 for a physician-based clinic, 19 or 22 for off-campus, on-campus. And again, we are using these so that if we were to see the patient face-to-face, CMS wants to know that that patient would have come in. Ergo, we would have gotten a facility charge accompanying that patient visit. So the facility charge for hospital-based, on-campus, off-campus, means about $115 in addition to, that goes to the hospital or goes to the ambulatory facility. And of course, for a physician-based, those are higher physician RVUs attributed to that work done on the fee schedule. I know I'm speaking in tongues now. It's just all wrapped up in my head. So for post-PHE, are the CPTs all going to revert? Well, not all of them. They the fee schedule folks have said that the codes that were added to category 1 are codes that are similar enough to codes already on the telehealth list. So they're just getting kind of grandfathered in. The codes that are in category 2 on that list, they're seeking comment. And hopefully we'll hear about those comments by the time this recording airs. Other codes have been added to something called a category 3. And again, those are the ones that are going to go away and go off the telehealth list once the PHE is over and the end of that calendar year has been reached. For instance, the PHE is over on January 15th. All those codes are going to apply up until the end of January or December 2021. So an additional 11 months of us being free to bill. Of course, that will take away the home as a eligible site. So there's a lot of things to consider. So modifiers, yeah, everything's going to go back to the way it was. Right, the HRSA geographic area requirement's going to revert unless Congress passes legislation expanding locations. I've also read comments where the CMS can expand on their definition of what rural really means. It's not hard and fast. Does rural mean people per capita? Does it mean people within a certain mileage? Does it mean cities that are, less than a certain number of population? So hopefully they're going to take these to heart and maybe expand that without having to have Congress change legislation to expand the location. Is the home continue to? Yeah, we said it's not going to, but it already is a valid originating site for ESRD home dialysis patients and patients that are receiving substance use or SUD disorder treatment in their homes. So beyond video, it's not all about video. We like to think it's all about video because we love video, but the telephone codes have been so great. 99441, 99442, 443, presenting problem and time-based. The e-visits, 99241 through 243, those can be used by essentially a provider who can submit an evaluation and management code. So we're looking at MDs, APPs, nurse practitioners, PAs, folks like that. And then there are also codes for e-visits for qualified health providers that are non-physicians. And there are also non-physician telephone codes too. Those haven't been put into great practice as of yet, but I can certainly answer questions about those. The brief check-ins, I've heard people are actually using these. They pay really minimal. They're about 5-minute check-ins with a patient. During the PHE, they're saying the patient can be established or new. These are generally for established patients. You're going to say, hey, how's it going, patient of mine? Currently, it can be, hey, how's it going, new patient? Do you need to come in? And if you do need to come in, let's make an appointment. And I will not bill you one of these codes. If you don't need to come in, I will bill one of these codes to Medicare. Again, I mentioned remote physiological monitoring, remote patient monitoring. These need clarification. These are our problem codes for this current fee schedule. And then I did mention, so more on that. There's going to be more on that. So just don't hold your breath, but it's going to be interesting. Self-reported blood pressure, I mentioned for hypertension, 99473-474. And again, here's the difference between the telehealth originating site fee and then the GEO 463. So there's been back and forth around what a facility can bill, what a facility can't bill, where does the provider have to be, da 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 da. My current understanding is if both provider and patient are off-site, they are not at the hospital base, on campus or off-campus location. In addition to that, we, the facility, may bill a Q3014, Q3014. $26.65 is the set price. It's a practice expense. It does not vary by location or by RVU or VU, value. They're not valued differently depending on where the patient's located. I mean, where the practice is located. So everybody gets that $26.65. If you're both offsite, and these are concerning hospital outpatient departments, this was to create equity for physician-based practices and hospital-based ones. Now, the G0463, we've been told, or we understand, them's in the industry, that, okay, the patient can be either on site or the provider can be on site, depending on your interpretation. Had the patient would have intended to come on site, then you get to charge that $115 facility charge. Work it out with your compliance people, take it back, hash it out if you haven't been billing it already. It's a lot of money. So facility providers, meaning facility employees, perhaps. So PTs, occupational therapists, SLPs, they can now bill to patients in their homes during the PHE. It is up to the facility to determine which services can be appropriately provided via audio or visual. Like anything, it's up to the facility. It's up to the ordering provider. Is this going to work for that patient? And then the services should really meet the complete and full intent of the CPT code that would be usually attributed to that service. There's no need to file for a relocation request to a regional Medicare office. There's been a lot of back and forth on that too. Just suffice it to say that. Okay, post-PHE, yeah, it's going to revert. Modifiers, yeah, revert. What we're hoping is, so there might be some continued demonstration projects like, the lower limb replacement or the lower joint replacement models. Again, the HRSA eligible geographic areas are going to revert. Will these providers be permanently added to the list of eligible telehealth providers? It's under review. It'd be great if they were, wouldn't it? Well, let's pay attention to the commercials. We have a few minutes left. I just wanted to give you a sense of there is so much data available, so much information available to you now during COVID-19. I would like to have anyone put in a comment or in the Q&A right now to say that, yeah, I had great success in finding telehealth policies for commercial payers prior to the PHE. That's going to be a big fat zero, isn't it? So this is in a sense, if you could type in Aetna COVID-19, you're going to find all these things, but I've just given you a few of the URLs to get you started, and then you can start building yourself a list if you already haven't, and then map it out. Don't worry your doctors about that, or your providers like your NPPs and your APPs. This is where us back-end people shine, right? We're going to get the right modifiers and the right place of service and the right codes going out the door. Everyone seems to have different ideas. It's allowed. Market-based economy, free market. People can sell services as they wish. A lot are following CMS. Some do not cover phone, some do cover phone. Again, just map it out for yourself, and you can use that to either enter in some workflows into your EHR billing mapping, or you have it at your elbow while you're doing charge entry. And here we have just a few resources. We all love the Center for Connected Health Policy. They have a multi-state Medicaid guide that will give you information on what your Medicaid plan will cover. The CMS telehealth codes, as they currently stand, are available at the next URL. And then the MPFS, the proposed Medicare physician fee schedule, is located at this URL. It comes as a zip file. You download the various files. Like there's the telehealth file, there's the gypsy file, there's the conversion factor file, there is the conversion factor calculation file. Important to know that the conversion factor is going down from 3609 to, I want to say 3426. It's gone down by about $4, or I think $3.83. That is the end of my presentation. Please enter your questions. We're happy to do any follow-ups that you haven't already asked during this presentation. And I'm so pleased that Palmetto Care Connections asked me to present to you and try to impart some of the information that has become so valuable to all of us during this health emergency, and then how we're gonna react to that after it's over. So thank you very much.